What if prostate cancer treatment could target that cancer with incredible precision while protecting the healthy parts of your body? On this episode of the If You Are My Brothers podcast, we explore proton therapy, one of the most advanced forms of radiation treatment available today. What is it? Who qualifies? And can it reduce side effects for men facing prostate cancer? Well, we've got some of the, if not all of the answers with our guest, Dr. Karen Godette, joins us to explain proton therapy and why precision matters in the fight against prostate cancer. I'm Reggie Hicks, your host, and welcome to everyone watching on YouTube, Facebook, LinkedIn, and also to those listening on your favorite podcast platforms. We want to remind you to like, share, subscribe, and also engage with us, which you can do at our website, ifyouaremybrothers.org. There you see it on the screen there, and you can leave us a voice message. You can leave us an email, and of course, you can also reach out to us in the comments down below this video on YouTube. We want to welcome you. We thank you for being with us on this episode of If You Are My Brothers. Our guest on this episode is Dr. Karen Godette. She's the medical director of Radiation Oncology at the Emory Proton Therapy Center. And she's also a clinical member of the Winship Cancer Institute, both here in Atlanta. She is a board-certified radiation oncologist. She specializes in proton therapy and prostate cancer treatment. Now, Dr. Godette has been recognized as one of Atlanta's top doctors and is widely respected for her leadership in cancer care, medical education, and community outreach. And full transparency, Dr. Godette, you are my oncologist, and you have helped me and guided me through my proton therapy treatment journey. So a little different on this end with me asking you questions, since you always, when I see you, you're asking me questions. So I like and I do ask a lot of questions too, but it's nice having you here through the weather and the traffic. So how are you doing? Doing all right?
I'm fine, thank you. And I just want to correct one thing.
Mm-hmm.
I'm the director of radiation oncology of Winship Cancer Center, but not the Proton Center.
Oh, okay. All right.
So right across the street.
Yeah.
But yes, I do work in both places.
I just gave you a promotion.
You
So
just gave me a promotion.
Look, speak it. You never know. So thanks for that. So let's get right to it. For those who may be hearing about proton therapy for the first time, can you tell us a little about what it is and how it differs from traditional radiation treatments that most people are familiar with?
Right. So the first thing I want to make sure we clarify, is that proton radiation is a form of external radiation. I think people think that it's not a form of external beam radiation, but it is. It's coming from the outside. The difference is the particle that is treating the cancer. On the proton side, it's protons that are produced from the cyclotron and via magnet that are treating the cancer. Now, the difference between the proton beam and the other beam is that the proton beam can stop where we want it, so it prevents the radiation being scattered to the nearby structures. So that is the main advantage of the proton beam. And one example I saw someone use, it's the difference between a flashlight and a spotlight. Okay, I think that's the best analogy that I found. I stole that from one of my colleagues. You're getting the same area, but the spotlight is more precise. So with the other beam, with photons, we're getting the same area, but we're getting a wider breadth of tissue around that we're treating. And with protons, we're a lot more defined in what we treat, so you're getting less scattered to the normal structures. In the case of prostate cancer, we're talking about the bladder, the rectum, and sometimes the bowels if we're treating the lymph nodes.
So let's talk about how proton therapy is personalized. Um, is every treatment plan unique to the patient?
Yes, every treatment plan is unique to the patient. It's based on the stage of the disease, which includes the Gleason score, the PSA, the imaging or the extent of disease. All of those are included. We also have the imaging. Did we have a PET scan? Did the MRI? What did the MRI show? What did the PET scan show? Were the lymph nodes involved? All of that's taken into account for each individual patient. So it's very individualized.
Yeah, I remember going through that process and then having even a mole that was done for me, for my feet and legs so that I wouldn't
Right,
move. And every time I would go in, they would line me up. I'd sit in, put my feet in that. And
right.
it was made just for me. It was, had my name on it and everything.
Yeah.
Um, are there better candidates for proton therapy, in particular when we're talking about prostate cancer? I mean, if somebody comes in, uh, I don't know, and it's, high Gleason score and cancer is
Yeah.
pretty, does that make a difference at all?
I mean, ideally, we prefer an early stage prostate cancer. I think we make more of a difference in an early stage prostate cancer in terms of the tissues around that we can spare. But actually, we could treat most prostate patients with protons. There are other things that actually would make the patient not a candidate for protons. So something like if the patient had a bilateral hip replacement,
Hmm.
they're not a good proton candidate because of the scatter that's caused by the hardware. That's one example
Oh, okay.
of someone that's not a good proton candidate more than the actual disease of itself. If the person has a pacemaker in and is pacer dependent, some proton centers treat those patients. We tend to not treat them unless we could turn the pacemaker off.
Hmm.
So
Okay.
those are some of the things that we're looking at more so than the cancer of itself, because most prostate cancers we probably can treat, although we may make less of a difference the more advanced the cancer is.
Does
Because
that
where it's
same
more advanced, it's involving the nearby structures already.
right, right. Now with the pacemaker, the hip replacement, is that the same if it was traditional radiation, the
So
photon therapy?
actually, in this case, the patient would do better on the more traditional radiation. Yes.
Oh, okay.
Yes. On the other side with on the photon side, you actually would get a better plan because the scatter affects the beam less. So you'd get a better plan
Ah,
over there.
right, right.
And it's less dependent. And in terms of a pacemaker, it's also about the distance and the beam. And so, yes, it's less affected if we do it on the photon side.
Well, I will say that my experience, because of uh, going through the treatment, I had some issues with the hydrocele that
Right.
that I had been. And for those of you who don't know, a hydrocele is, it's, I don't know,
Fluid
fluid, yeah,
in the test. Yeah.
in the testicles,
Scrotum.
and
Mhm.
it doesn't really hurt or anything. It's not, like something you got to worry about. Just the
More
presence of
inconvenient.
it. Yeah. But I do remember you were saying that, that was going to affect how the beam would line up. And see, I had a couple of times had gone in just to have the hydrocele, just the fluid extracted. And
Mhm.
the urologist, the doc would say, you really need to get it fixed. And I was like,
Right.
well,
Yeah.
you got about a 15% chance of this thing, not coming back. And I was like, well, I don't know. And then you said that to be really
Right.
effective, we need to do it. And that caused me to have it done and get it out the way,
Right.
prior to my
So
treatment.
we're very precise in our measurements, as you know.
Hmm.
And even during the treatment, we do what we call quality assurance CAT scans So we're remeasuring to make sure that everything is precisely the way initially planned at the very beginning. So if you lose weight, if things are
Mm,
different, anything that's different, because it's so precise, every little millimeter counts. So we want to make sure that we're getting the adequate dose to the target.
right,
And if we're not getting an adequate dose to the target and the dose is going somewhere else, that means that you're getting the normal tissue that you would not normally be treating.
right.
So we have to be accurate.
Yeah, that precision piece is really important, and I experienced that. So a person comes to guys like, okay, I want to do this.
Hmm.
I want to do proton therapy. What's that? And I'll chime in too because I
Hmm.
experienced it. But
Your
so,
experience, right?
so what is that like? So now you've come in, you've done. I know you have to do measurements and a couple of MRIs and some other things. So after all of that, I'm lined up, I'm ready. What does that look like?
So you're asking before you begin or when you're on the machine or
Yeah,
which?
when now that we've gotten the preliminaries out of it, well, we talked a little bit about the preliminaries. You can go back over that if you
So
like.
let's go over.
Yeah.
So you come in for the consultation.
Hmm.
We review the pathology, we review the imaging, the Gleason score, the PSA, kind of decide which risk category prostate cancer you're in.
Hmm.
Like I said, of course, the earlier you are and the longer we're going to live to see the side effects, of course, the more benefit you get out of it. But once we decide that, we do the planning for the radiation and the planning session. Before we get to the planning session, not in every patient, we may insert markers into the prostate and a gel beneath the prostate to decrease the amount of radiations going to the rectum.
Hmm.
I do want to stress everybody is not a candidate for that. So if there's any cancer outside of the prostate, we're not going to put something in the rectum that could affect the cancer that's pretty close to that. So we don't. Everybody does not get a rectal gel, and it doesn't mean you're going to have a worse outcome. So I
Right.
want to stress that because some patients feel that because they didn't get it, it's going to be worse. It's still fairly well tolerated. And people who've had prostatectomies are not going to have a gel put in, and we still treat those patients. So we don't
Yes.
have to have it. We don't have to have it, but if we have it, it's great. So I just wanted to say that. Once we do the planning, the markers and are put in, then we do the planning session where you make the mold. We make the mold for the patient and you do a CT scan and an MRI and use those images to do the planning for the radiation. Once the planning is done, then the patient goes to the machine. The marks that are made in simulation are the marks we're going to use to set you up every day. And a lot of times you feel them tugging one side and tugging the other,
Yeah.
trying to make you straight.
Right.
But they're also trying to line up, if you have markers in the prostate, they're trying to make sure those markers line up every day. If you don't have markers, then they're using the CT scan to make sure the images match every day. And every day they're going to take pictures, and every day the radiation oncologist reviews those pictures to make sure that everything lined up that day at treatment. And the therapists are there to look at the films as you're being treated to see if it's not lining up. Is there too much stool in the rectum?
Hmm.
Or is there not enough fluid in the bladder? All of those things are important and they're looked at on a daily basis for each patient.
Well, let me just speak to that.
That's the hardest part, actually, for most
That
patients.
yeah, there's no pain, there's no like discomfort, outside of uh the having the bladder full
Oh, and the
and
rectum empty.
the rectum empty.
Two things at the same time.
Yes,
Yeah.
and I think when you don't have a prostate, it's even more of a challenge.
The harder for
Uh,
the bladder.
right, right.
Yeah.
But I will say this, in talking to other patients, which I would always suggest whatever treatment that you decide on, and
Mhm.
the folks there that sort of do your intake and orientation, they do an excellent job. And one of the things they do is they allow gave me a couple of names. As a matter of fact, one person I call I knew, didn't know he had gone through the process, but I knew
Mhm.
him, and he gave me some really good advice. And I think at the end of the day, I learned how to pace myself. Like I'd have a bottle of water on the way. It's about a 30-minute drive from my house. And then I'd
Mhm.
have another one right before, one or two before I went in, for therapy. And just made sure that I went to the bathroom, as I used to say to my son that, do number two. And
Mhm.
so it kind of worked itself out. So I had this kind of routine after about 3 or 4 times.
Right.
What's interesting is the first time I went, the technician was so proud. He's like, "Man, you are right on. You are 100%. I wish everybody would come here like this." And then it became a challenge, right? to be that way every time. But I will say, getting off of the table after about 6 or 7 minutes, that's when, it's kind of like, oh,
Everything, yeah.
right. Gotta go, gotta go.
Yeah,
But
but you are right. After prostatectomy, it is a little bit harder. And the reason is the prostate's removed. So the bladder is sitting exactly where the prostate was. And then
right,
we have to treat where the prostate was in a post prostatectomy case. So you end up treating a lot more of the bladder than you would normally if the person has an intact prostate.
right. Well, I was able to make it work, but I did have a
Hmm.
question. So I did 37, I
Hmm.
think, treatments,
Right.
you know, Monday through Friday, off on the
Hmm.
weekends. How do you determine the number of
Of
treatments?
treatments. So a lot of this, we're doing this based on trials that have been done in the past.
Hmm.
And some trials actually that are currently going on. And let's start with the intact prostate first.
Hmm.
For the intact prostate, we actually have like three different treatment courses that we offer. We have a 5.5 week course, we have a 4 week course, and we actually have a 5 day course or SBRT,
Hmm.
which we treat 5 times, once every other day. Now, traditionally, we actually treated prostate cancer in 8 weeks.
Wow.
And the studies show that we can now do that shorter. And places like England and Canada, where people don't have as much access to radiation facilities, they had come up with shorter treatments because people were waiting longer.
A longer time,
And
right?
so they were some of the first people to do some of those earlier trials where they did shorter treatments. So now we have a 5.5 week course, and we have a 4 week course, and then we have a 5 day course. Everybody's not offered, say, a 5 day course because your prostate cannot be too large because the dose is so large. You
Mm.
can't have a large prostate. We don't treat lymph nodes with that because that's a bigger field and the dose is too high. So there are a lot of other things. And if you have a lot of obstructive symptoms, like getting up a lot at night already, having to take medications for urination, all of that before, you're not going to be a good candidate for doing it in just 5 treatments
5 days, right?
because you're getting everything all at once. In the post prostatectomy case, because you've had surgery, we don't go as fast. We go a little bit slower
Hmm.
because now we're in an area that's had surgery before. We're treating more of the bladder, so we go a little bit slower. So we keep more of the traditional dosing that we did rather than doing it quickly. There's a quicker form of that, but most of us kind of keep it to the traditional slower dose per day. And we've been doing that today. So it's just as time goes on and we do more studies, we see that sometimes the shorter, we have to prove first that shorter, although it's faster, that the toxicity is not greater.
Hmm.
And we have proven that for those schemes that I've told you.
So
So that's how that works.
yeah, and I wanted to just mention too, when you
Mhm.
talk about like in other countries where facilities might not be available. Now, proton therapy centers are not
Right,
everywhere, right? I know I
correct.
visited the one in Florida,
Right.
in Jacksonville. I know there's one at Loma Linda.
Yeah.
Got a chance to see that one, and and then is it Houston? I think MD
Houston,
Anderson.
right now, yeah, right now, MD Anderson
Hmm.
does have one. But I do want to say when I'm saying facilities, I just mean radiation in general, not
Yeah,
even
yeah,
proton
yeah, yeah, yeah. And that's why I
centers,
just
right?
brought up the fact that
Yeah.
you know,
Actually, in the country right now, we have 48 facilities.
mm, I did not know it was that many.
It's it's gone
Oh wow,
up. Yeah, I
wow.
just checked it before I came on today.
48. I remember
Yeah.
maybe 10 years ago, 11 years ago, because I was considering that
Mhm.
when I was initially diagnosed, and it was maybe 5 or 6, maybe. I don't remember there
Right.
being, wow, 48. Now,
But
it,
quite a few of them are actually going out of business also. It's
ah,
an expensive machine to it's a expensive proposition or machine to
yes,
run.
yeah, yeah,
Yeah.
and it's a blessing that we have one here in Atlanta. I remember when it was being built
Right.
in Midtown, and I was like, yeah, "Wow, this is no, you don't have to go to Florida now, or you don't have to go,
Right.
somewhere and rent a place for 2 months or whatever," which I was considering in
Mhm.
Jacksonville for a minute. But yeah, it's great that we have one here in the city, and I noticed too when I was there were people coming from Athens and other
Right.
parts of the state.
And people from
And
the south too. We have
yeah,
patients from yeah.
yeah. So that's good. I Now getting back to, let's talk about side effects.
Side effects. Mhm.
Yeah, side effects during treatment, and then side effects, if any, after
After
treatment.
treatment.
Hmm.
Okay. So in terms of the side effects during treatment are going to be, first of all, urinary symptoms. Those are going to be noticed first. And that would be more in the order of increased urgency. You got to go, you got to go. Frequency, going more often. Nocturia, getting up at night,
Hmm.
go. Sometimes even some mild burning with urination, or occasionally even some blood in the urine. All of that would be considered part of the course. Then we have a change in bowel habits. Your bowels may move a little bit more frequently. The consistency may also change with that. And lastly, we have well, not lastly, we have some fatigue.
Hmm.
All of this is a gradual process, though. It's not something that happens all at once. Most patients, they're treated for 2 weeks and they're like, nothing's happening. And all of a sudden, it kind of catches up with you.
Right.
And right. And the only other thing I didn't mention beside the fatigue is that where the beam is entering the body, you're going to see skin changes, either some redness or some tanning, but it's generally not a big area. And a lot of people, unless you tell them, they're not looking down to see where it's coming through the hips or whatever. But some of this, like I said, it just takes a while for it to happen. And sometimes it doesn't really happen. Sometimes we have to give medications for some of the side effects. And we can't always assume, say somebody complains of burning, we can't assume that it's all from the radiation. It could have an infection.
Hmm.
So these are the things that we discuss when we meet with the patient once a week to make sure there's nothing, we don't need to give medications to help with any of the issues that the person is having. And just in general to see overall how the person's doing. The good thing is that once we're finished, a lot of this slowly gets back to normal. Although sometimes the patient has a new normal after radiation, and patients have to remember that. You may never quite get back to what you were before nothing was done, but I expect you to be better than when you finished treatment.
Is there a difference between someone who has a prostate that's being treated versus someone like myself who has had the prostatectomy? And is there a difference as far as side effects during treatment?
In terms of, no, like I said, for the post prostatectomy case, there's a lot more urinary symptoms and it happens quicker.
Yeah.
But other than that, you're going to still have the same rectal issues, the fatigue, and all that. And we did not mention the side effects of hormones, which some people are on hormonal therapy, and you have to add that into the mix because on top of these side effects, they're now having hot flashes, night sweats, you know, sometimes their emotions are kind of going up and down.
Right.
And there's some fatigue and all of that associated with the hormone therapy also.
Yeah, I didn't really have what I didn't have the hormone therapy, but I didn't have any real issues. Fatigue was probably my biggest issue, but I will
Okay.
say that what I did appreciate, like you said, was every once a week, there was a check-in.
Right.
And you sat with the doc and ask your questions
Review
and how.
everything.
Yeah. So, that was really, great as far as just kind of keeping track with how I was
Right.
feeling and what I might need it, in
Hmm.
getting through it. After it's over, what can someone expect to happen once the treatment's done? You know,
Hmm.
uh, what's next? What are some
So
folk
the first thing
experience?
is that most patients, even during treatment, they want to know, how is this working?
Yes.
Doc, how do I know this is working? It's like, I'm
Yes.
coming every day. You're not telling me anything. Can you see the cancer? So first of all, I can't see the cancer when you're being
Right.
treated.
Right.
And all we're doing is doing a CT scan and sometimes an MRI. So we can't see the cancer on the treatment. We do not take the PSA right after you're done. We need to wait for things to calm down. So generally, the rule of thumb is we wait 3 months before we get your first PSA. And I know it's a long time to wait, having been 6 weeks of treatment or 7.5 weeks to
Yes, it
wait three
is.
months. It's a long time. The thing is, if you took it before and it was a little bit high, everybody would freak out. So you kind of have to take it slow and wait for things to die down, right?
Right.
So yeah, so that's the one thing. But in terms of expectations, things slowly do get better with time, but radiation does have long-term side effects. And there's side effects of radiation that you may not see for a year or two or 3 or 4 years from now. Because the bladder and the rectum are close to the prostate, the radiation can affect those organs, but you see a late side effect, such as blood in the urine or blood in the stool,
Hmm.
like a year or two from now. And that's why I always ask patients before we get started if they've had a colonoscopy. And if they haven't, we need to get it done before. So we're not worried that if we have some bleeding that they have a colon cancer. And I have discovered many colon cancers just doing this,
Hmm.
because there are a lot of people who've never had a
Right.
colonoscopy.
Right. Right.
And in the whole picture, colon cancer, you know, we have to worry about colon cancer a lot more than we do with prostate cancer in terms of a serious cancer diagnosis. And so if that did happen a year or two from now, we don't assume everything is from radiation. You see some blood in the urine a year or two from now, we're not going to assume it's from radiation. It could be, but if it persists, you do need a cystoscopy for them to look into the bladder to see if is anything there. And many times the doctor may just see inflammation of the
Hmm.
bladder caused by radiation, or look into the rectum and see inflammation caused by radiation. But you can also have something like, well, not something like, you can have erectile dysfunction
Oh
after
yeah,
radiation.
that was going to be one of my
Although
questions.
something, things like damage to the bladder and the rectum and erectile function, there is some evidence that we do better with protons, but it's still a possibility that it could happen. And many times when patients decide they want protons, they're thinking that some of these things are not going to happen,
Hmm.
and they still can happen. I want to make sure that's clear, although there may be less chance of it happening, less chance of bowel issues, less chance of bladder and erectile issues, and sexual function, those types of things. And also things like a second cancer that can happen radiation after radiation too is a little bit less with protons. So
Hmm.
although they're less, they are still present.
Present and with traditional radiation, those
Mhm.
things, like you said, well, can happen,
Right.
as well, and
Right.
maybe happen more. So for someone like me, I've been out a year, a little over a
Hmm.
year, and I'm okay, I think.
Mhm.
I remember that first PSA, which was really that was a little I as a matter of fact, I think I went in to actually I followed the nurse in as she
Mhm.
went in to to check the PSA, and she looked around, she looked behind her, she says, "Oh," and I said, "Has anybody ever followed you in here to?" She said, "No, you're like the first person that's ever
Right.
like followed me." So I actually went in and we all
To see
watched
her,
together.
yeah.
Yeah, yeah, as and it was undetectable. And I will say this, there was some discoloring.
Mhm.
And as a matter of fact, one of the persons I called said to me, and he had been out, a year or so, and he said, "Yeah, use some cocoa butter every day and or
Mhm.
shea butter." And he
Right.
says mine's gone, and here it's a
Vitamin
year
E.
later, and it's
Mhm.
gone. I mean, my wife's like, you don't have those dark marks anymore, and I was like, yeah,
Mhm.
'cause I
Right.
don't know what to
It
do.
fades.
But should I be concerned? I didn't have the hormone therapy.
Mhm.
And so far, I think 3 times I've had, PSAs, maybe 4.
Mhm.
It's been undetectable. Um, so one of my concerns is, as you mentioned, with radiation, that other cancers can happen,
Mhm.
and does that
Later.
later, is it a lot later, or is it on average,
Generally,
or
it's about 10, maybe 10, 15 years later.
okay. All right. So it's not something I have to worry about like tomorrow.
No. If your cancer came back, it's not because, I just want to be clear, it's not because
Yeah.
of radiation. Some people don't
Right.
quite get the difference. The cancer that's caused by radiation is generally going to take some while to show itself,
Mhm.
and it's generally going to be cancer of the bladder or the rectum in the area that was touched by the radiation,
Mhm.
or
Right.
the prostate of itself, a
Right.
different type of prostate cancer, say. So it's going to be in that region. It's not anywhere else in the body.
Right. Well, so far for me, it's and it was a great experience as far as having treatment. No one wants to go through treatment. I didn't want to have to go
Right,
through it, but
right.
I think as far as like you said, there are some side effects I didn't experience a lot of those other than the a little fatigue. And I was fine. Nothing really changed that much for me.
Mhm.
Was already had issues within, from the prostate being removed. So
Right,
I
prostatectomy.
yeah, yeah. So I already had some of those issues. I don't remember. I think the frequency might have picked up a little bit and then it kind of
Mhm.
settled down. Um yeah, we talked about, and you've been a wealth of information for me and on the podcast as well. So, is there anything that we missed? Like the man's diagnosed with prostate cancer. What questions should he ask you when considering radiation options like proton therapy?
Right. So one of the things that the question you get asked the most is, uh, why should I get protons, and is protons better? Okay. So in terms of, let me go with that question first. In terms of survival from prostate cancer, I want to make it clear that we cannot say protons are definitively going to make you live longer from prostate cancer. It's more the toxicity profile that makes protons the advantage for prostate, not the survival. And this is still a very big debate within the radiation therapy community. And there's some proton centers who don't even treat prostate for that reason. So I want to make sure we have no randomized trials comparing protons and photons to say that protons are definitively better. And because a lot of this has to do with the fact that on the photon side, we've gotten a lot better. So the difference between the two is very little. And so some people feel that we shouldn't, some insurances especially consider protons not medically necessary. But in terms of the treatment options, when the patient comes in, you know, What are the things they ask? You want to know what your options are. Always want to know what your options are. And hope that the person is being subjective when they tell you about your options. If a surgeon only tells you about surgery, that's probably not right. And if the radiation oncologist only tells you about radiation, probably not right. Unless it's more advanced, then surgery becomes less of an option. But for early stage prostate cancer, you want to know what are your options based on your stage. Is it internal radiation, external radiation, combination of both? You know, what are the big differences between radiation and surgery?
Hmm.
And some of those are simple. Surgery is invasive, but you're removing the cancer, it's gone.
Right.
But it is an invasive procedure. There is a recovery time, and incidences of incontinence and erectile dysfunction are going to be higher. The probability of it happening is higher with surgery. But by the same token, you could always do radiation later if the cancer came back.
Hmm.
It's not the same with radiation. If you do radiation first, surgery generally is not going to be your option if the
Right.
cancer came back.
Right.
But overall, you want to know what your treatment options are. You want to know if you're a candidate for protons. And like I said, a lot of that for insurance is more insurance driven for prostate cancer in terms of you being a candidate or not. And the other things like I talked about with the hip and the heart, the pacemaker and the hip replacements, those types of things. You want to know how the treatment is going to affect your sexual function. You want to know how it's going to affect your bladder control. Are you going to become incontinent? And a lot of this too has to do with how well you are going into the treatment.
Hmm. Hmm.
If you're having a lot of issues before, you are going to have a lot of issues
Right.
after.
Right.
Radiation is not going to make that better. And there are some patients, I know it's boring every time we give you that scorecard to fill out how you're urinating and all that, but that actually tells us which patients may actually need a procedure before we even start radiation because they're having a lot of obstructive symptoms before we start. And you
Hmm.
don't want to get into a case, which we've had, where the person says everything's fine. We do the radiation. In the middle of the radiation, they go to the emergency room because there's urinary retention, because they had issues before and it was not addressed.
Hmm.
So that's why we give you that scorecard, because if you have a certain dose, it's telling us you're going to run into problems.
Hmm.
And so you may need a procedure first, even before we begin. And if you have to have a procedure like a TURP or green light laser or aquablation or any of those things that they do for like BPH,
Hmm.
then you have to wait 3 months before you get radiation. And
Ah.
some people, you see, so all of that has to be taken into account where you are before you start, so we could give you a sense of how you're going to be done. And then the question comes up if you need hormone therapy or not. And that is stage dependent. Also, Gleason score, all of those things are going to come into the discussion in terms of if hormone therapy is needed.
Hmm.
So those are some of the things you have to ask, at the time. And when you're considering, you also want to consider what's the best thing in terms of your quality of life.
Hmm.
Do you want to do
Right.
internal radiation instead of coming every day? You know, do you want to do internal high dose rate seeds, all of those other options? So you have to know what your options are, then figure out what's best for you.
Yeah, and I think what you said too is, not just going with, because I know through my experience, certain docs did certain things and they gave you information, but it was more, but this is what, I would, not necessarily
Right,
recommend, but it kind of puts you in that one area.
right.
And I found that really taking the time and going to different places and understanding what the processes are, where you can make a choice that, like you said, that kind of fits where you are, and
Mhm.
that's so important. Let me ask you this: has there been a patient, or is there a patient story that has stayed with you throughout your career in doing this? I know that's a kind of a hard question because you see so many people, but
No, I'm trying to think. I mean, people stay with me for different types of reasons.
hmm
You know, I have patients who sometimes are very, patients stay with me different reasons. I've had patients who've never had a female doctor.
ah, yeah,
Um, and I can tell that it's, I can tell that going into the room. And I've had a gentleman apologize to me for that.
hmm
Um, which was, um, you know, I didn't think he realized that I realized that he had an issue with me being a woman.
yeah, right.
But I mean, actually, I had a story that touched me the other day. I had this patient who had relocated here and came because of he'd adopted his grandson, um, because he had adopted two siblings, and one of the guy had he had emotional issues, and I guess more on the was on the spectrum. And so he moved here from New York for the kids and to provide, he and his wife provided a home for them. And it was touching to see his dedication to his son, his adopted son, and trying to fit his diagnosis of cancer and deciding about treatment around that. And it did turn out to be one of those cases where, after we did extra testing, because you can do extra testing on these, now we've come a long way in terms of making choices. Before, they told you a Gleason 7, you just had to sit with it. And then he said, oh, you're intermediate, unfavorable, you have to take hormones. Now we can do decipher testing, Artera testing, to tell us if you really do have to take the hormones and if the hormones are going to help you. It's not a routine anymore. They're doing genetic testing on your particular sample.
Mm, okay.
And for him, we were able to do that. So he was able to be comfortable with active surveillance for a while so that he could concentrate on his
On
family
his family, right,
and not do radiation right now,
right.
because there was a lot going on. And so a lot of these things, you do have choices, but it's good for us to be able to, impact your quality of life as well as your overall life from choices that we make with treating prostate cancer. Everybody does not have to be treated and have to be treated right now. And in these cases now, you can know who you are, if you need to be treated or not.
Yeah, and we just had a guest on who is a journalist out of in Alabama, and he's been chronicling his active surveillance journey,
Hmm.
which is interesting because when I started researching treatment options, like now, active surveillance is like right at the top. And I
Right.
remember that was like, oh no, that was way down at the bottom. Nobody wanted to wait. And, with cancer, we got to
Right.
get it done right away. And it's just nice to know. And I did that. I kind of leaped at one treatment, and it didn't pan out because I didn't have insurance, but it allowed me to wait and really kind of say, okay, well, let me kind of look through this thing, and let this be a part of the documentary I'm doing. So I was able to, because of my Gleason score and everything, I was able to wait
Mhm.
and really find what, for me, having the prostatectomy was always at the bottom, and it kind of went to the top
Right.
as I started doing my own research. So let me ask you about this as we kind of close out. What breakthroughs in radiation oncology are you most excited about right now?
Actually, they're doing some work, um, with flash therapy and radiation now, where they're giving like these really high doses, even beyond what we're doing now.
Mm.
Um, we're also on the other end of radiation with the internal radiation. We're now doing it's new for us. I shouldn't say it's new for everybody, but now at Winship in Midtown, we have our own high dose rate suite where we could do the internal radiation right there. We don't have to take the patient to the operating room. We have the OR suite right there. And now we'd be able to do real time dosimetry where we could do all the planning and everything in the operating room and not move the patient,
Mm.
which is really, really great.
Right.
Um, Beyond that, you have nuclear medicine studies that are being done, where before we didn't have options for men with advanced prostate cancer, but now they can get lithium. I mean, there are a lot of other things. And now we have immunotherapy. There's a lot of other aspects of prostate cancer besides radiation, too, where they're making headways. Something simple like the hormone therapy. A few years ago, we didn't have pills to offer patients. Everybody had to get an injection.
Mm-hmm.
Now we can give Orgovix, which is a pill that you take every day. And so when you're finished with the treatment, your testosterone is going to rebound quicker because it's not in your system as long,
Mm-hmm.
right? And it also has less cardiotoxicity. So your heart is, if you have heart issues, that's a better drug. Before we didn't have some of these choices. So it's not just radiation. And, now we do have a proton registry, and hopefully with the registry, we may be able to show in the future to insurance companies and those types of things that protons are better if we don't get some randomized trial to prove it. But all
Right.
of those things are little bits to try to do it. And now we do SBRT. So we may be doing more patients at 5 fractions or something less than that. There are some places that are trying to do lesser
Less than
treatment.
fine. Wow.
Always. Yes.
Wow.
So, you know, and as we move along, even as I've started this, even the rectal gels that we use, they have changed. We started with spacer, only that. Then we have Barrigel. Now we have Bioprotector. All these different gels that are being used. All these different, barriers that are in place. We have different markers now that are being used. So as we're going along, everything is changing in every aspect of prostate cancer. Everything is changing. And the imaging. We didn't have PSMA PET before.
Yeah. Right. That was
We just had
something that. Yeah.
a regular PET scan. Now it's
Yeah.
more specific for prostate cancer. And soon, what's coming up is, can we do just focal therapy with radiation? Because so far the studies haven't panned out for that. But that is something, the better we are with the imaging, is the better we are in terms of, we do focal therapy for everything else, but we don't do it for prostate cancer with radiation per
And
se.
and when you say focal therapy, is that
I
just
mean, just where the cancer
cancer
is,
is?
rather than
Right.
treating the whole thing. Because even with protons, we still treat the whole gland.
Right. Right.
And we only do focal therapy if we're doing like a recurrence or a bone metastasis or something like that. And even those things, no, we treat with a high dose radiation for a few treatments and we're done. We
Mm-hmm.
didn't do that before. You got bone mets, that was it. Now it doesn't matter. We can give a rifle shot to that area, high dose, ablate that cancer, and the patient just moves on. So prostate cancer is more like a chronic disease now than it used to be. And it's a good thing because every time something happens, we have something else to offer you.
Yeah. That is wonderful. I did want to ask you just one thing that came to mind. Are you
Mhm.
seeing more men that have had prostatectomies having a recurrence, or is it not that it's, or maybe it's we were able to detect it earlier and it's coming up more, or is it pretty much the same over time?
Um, I haven't seen more men having a prostatectomy. I think actually a few years ago, I thought it was more just because it was a new thing.
Mm-hmm.
Robotics was newer.
Mm-hmm.
And so to me, I saw a lot more of it. But then it was a learning curve too. And I thought a lot of people had stuff left behind,
Oh
trying to
wow.
do it robotically, you
Wow.
know.
Yeah.
No, I don't know that I see more. But then a lot of times I'm probably not seeing those patients honestly. So a urologist would probably be able to see. If I see a post prostatectomy case, it's because their PSA didn't go down
Mm-hmm.
or they had positive margins or something like that. So
Right,
I'm seeing
right.
them. So it's, I don't think it'd be fair for me to say I'm seeing more just because I honestly, I only see the failure
Mm, right,
of a
right,
prostatectomy.
right.
Right, right. And robotics, though, I mean, to be truthful, has made things a lot easier. The recovery is a lot easier. You
Yeah.
know, the chances of incontinence and erectile dysfunction, of course, is less, but of course, it's always there. You
And
know,
is it less if, and I'm speaking from my own experience,
robotics.
having a prostatectomy, but had for a patient who, they found out they have prostate cancer, they come and they have proton therapy as their initial treatment.
Right.
Is it the erectile dysfunction, incontinence? Is that less, or than if you have it removed,
Right.
or does it
Right.
more?
So I could tell you right now that if you're not having any bladder issues, your your chance of incontinence is actually it's very very low.
Hmm.
The only time you should have incontinence with radiation or will is if you were having some problems before that
Before.
were, before. You shouldn't have incontinence just routinely from radiation. In
Hmm.
terms of erectile dysfunction, you can have some erectile dysfunction, but it's not like some patients in post prostatectomy where there's no erectile function at all.
Right,
It's more that you may need some help
right,
after radiation.
right.
So it's more like that. And you would do the same thing as you would otherwise, Viagra, Cialis, those type, you do the same thing as you would if you did not have radiation.
Hmm.
So if you just came and just presented yourself, erectile dysfunction and incontinence, the chances are better with radiation versus surgery.
Yeah. Well, I found that that aren't we
But
know
you have
today.
people that could go both ways, right?
Yeah.
You could
Right.
go with radiation, you're like, okay. But yeah,
Yeah. Yeah.
it is higher.
Yeah. Yeah.
It definitely is higher. But
Well,
you
yeah.
know,
Yeah. But the
but
good
then
thing
if you
is,
just did external versus brachytherapy probably be a little bit better. So
that's what
each
yeah.
one of them
Okay.
has a different
That's a
levels.
different,
Yes.
yeah. Yeah. But
Yeah.
I will say that the reason I think I went and I had the prostatectomy was because of a person that's a researcher who said to me, asked him, he researched prostate cancer. And I said, what would you do? And he said, I'd have it taken out because if something were to happen,
You could
then
also do radiation
you can
later.
do radiation. And
Yeah.
I'm like, oh, okay, that makes sense. Not ever
Right?
thinking that it would actually come back. I just got one other question. I got two questions and
Sure.
I'm gonna let you go. One
That's okay.
is, so why is it called biochemical recurrence and not just you
Recurrence.
got prostate cancer again? I mean, recurrence. Yeah. Why is that? Yeah. Because when I saw it.
Right. Because many times, most times we use that term because it was detected because your PSA changed.
Hmm.
But a lot of times we don't see anything.
Right.
So it ends up being a lot more biochemical than say physical in that sense.
Right. Okay.
So, and it's hard for patients for us to explain why the PSA is going up after a prostatectomy and they do a PET scan and we don't see anything,
Hmm.
right? So
Yep.
that's a true biochemical recurrence
Gotcha.
versus just saying a recurrence. But generally it's because you're not having any symptoms. So it's
Right.
discovered by the cancer by a PSA rise. And so
Right.
that's how the term came about because of biochemical recurrence. And
Gotcha.
sometimes we never see anything on imaging,
Yeah. We
or it
didn't.
may take a long time for the
Yeah.
imaging. So we don't see anything in imaging, it's just biochemical. So now
Right.
we're going by where we think it is because of where it was.
And I do have this. So that happened to me,
Hmm.
and we treated the prostate bed,
Prostate bed.
and
Hmm.
now it's gone. So I guess that's a good sign that that's
Right.
maybe where it is.
So we're treating where we thought it was because
Yeah.
that's where it was. And
Yeah.
the fact that the PSA's dropped, that means we got the area where it was.
Right.
And that's what about, versus sometimes patients, we've learned over the years that it's no point waiting for it to show up once the PSA gets to a certain level,
Right.
right? But if we wait long enough, I'm sure something will show up. But do we really want to wait till we see something versus treating something that's microscopic,
Yeah. Yeah.
right?
And that's probably why the hormone therapy along with it is a good thing, because it's like a double dose of,
Right.
because it is
So whatever
biochemical,
we
right?
don't get where we're shooting it, whatever is
Right.
floating around everywhere else, you're getting it with the hormones,
Right. Well, so if
right?
something happens, I'll be back. I'm just praying. I'm praying
And
that,
we'll be
that
able
we're
to treat
good.
it too.
I'm praying that we're good. How can folks learn more about proton therapy?
They can go to the Emory Proton Center website,
Hmm.
and also somewhere simple like the American Cancer Society, where they give you all the options. And I always say again, know what all your options are.
Right.
Um, but I would just say go to the Emory Proton Center website, or do your research on protons and see where you are. And you have questions, just always ask. Because all states are not like Georgia, where it's so insurance dependent.
Mm. Hmm.
Um, and unfortunately for us, that's where we are right now.
Right.
For our
Right.
state right now, it is insurance dependent.
Right.
And, I hate patients coming and this is what they want and they can't get it. But just remember that it's not affecting your survivability from prostate cancer.
Right.
It's the
Absolutely.
toxicity. And the bottom line is the toxicity with photons is pretty good.
Hmm.
It's been around, we've gotten a long way. So, although we can't stop the beam exactly where we want it, we can actually decrease the intensity of the beam so that it causes less side effects to the nearby structures. So, although it's less scatter, we can still do a lot of good with decreasing the intensity of the radiation, intensity modulated radiation on both ends.
Great. Well, thank you. Is there anything else? Somebody, guys watching this, but I think you pretty much said, do your research, right? And I will say this too. One thing that you did mention, and I remember, I still fill out the
That
form.
form,
Yeah. Be honest about what
yes,
you're going
don't
through.
cheat.
Yes. Right.
Because I can tell you, I know when you're cheating. If I treat you for 4 days or 5 days and you're having problems, you have problems before we started.
Yeah, right, right. So I
Right.
just want to say, just be honest, be open, and that way
Yeah.
you can help us. Anything else,
Yeah. And
Doc?
the other thing I want to say about that too is because you're used to getting up 3, 4 times a night, that doesn't mean that's the way it's supposed to be. It could
Hmm.
be better.
Yes, right.
So
Well, Dr. Godette, thank you so much for taking the time,
you're
weathering
very
the
welcome. I
weathering the
enjoyed this. I
weather
was kind of
and the
scared
traffic.
going in, but I enjoyed it.
Oh, you were great. You were great. And it was good being on this side of things this time. So thank you so much. And if this conversation has helped you, please like, share, and subscribe so you're alerted for other future episodes. I want to thank Dr. Cadet for helping us better understand the evolving landscape of prostate cancer treatment and for the work she continues to do on behalf of her patients like me and families every single day. So, Doc, thank you so much for what you do. Now, again, as I mentioned before, if you want to learn more about what we're doing, which includes a documentary, this prostate cancer series, and our community engagement work, you can always check us out at ifyouaremybrothers.org. That is ifyouaremybrothers.org. And the project really is dedicated to turning prostate cancer awareness into health action, and it is a project of the nonprofit organization Straight Street Media. Now, us being nonprofit means that any support is tax deductible. So we want to remind you that we really appreciate any contribution to our efforts, and it's available there. You can see different ways to give on the screen. It's also, if you're listening to this on your favorite podcast platforms, it is in our show notes as well. And I also want to remind you, when you make that contribution, you can scan the QR code, you can visit our website, you can even mail us a check, I tell you. But it all goes to helping us help others. And we appreciate everyone that supported our efforts so far. And when you do support us, you get, as I do my Vanna White every episode, the If You Are My Brother's official commemorative coffee mug, and that can be yours for any contribution to the cause. And we also want to thank Atlanta Brand Central for providing the mugs for us. They donated the mugs, so thank you so much. And other special thanks to our producer, Danny Garcia Pozo, who is probably pulling his hair out now because we had some issues for me and my dog Eddie here, so he's got to do some editing. But Danny does a wonderful job, and Danny, thank you for all you do. Zach Reynolds at Borkhouse Productions, also for producing our opening that you see each and every episode. Now, remember, as we always say, this podcast is not a substitute for medical advice. Always talk to your healthcare provider. Now, in 2 weeks, we begin our Men's Health Month special. June is Men's Health Month. And our first episode features another doc of mine, my primary care physician. And we're going to drill down into the front line of staying healthy, which is the annual physical. Yes, we're going to talk about that. We're going to talk about what to look for, what to ask for. And of course, when it comes to the physical and the prostate, we all know that old DRE and some other things you got to do. So we're going to also talk about that as well. Looking forward to having the doc on with us for that. Now, we'll be doing shows throughout the month of June, dealing with cardio health, dealing with staying healthy as far as exercise, and even looking at some homeopathic things that you can do to stay healthy as well. So we're going to dedicate June to Men's Health Month, and we hope you'll join us then. And if you subscribe, you can always get notifications as to when we drop our podcast. Now, until next time, we want to remind you, if you are my brothers, please share this message, and remember, we are in this fight together. So take care, stay healthy, and as always, keep the faith. Peace.